So what comes to mind when you hear mental health or
Mhm.
mental illness?
Yeah, it's interesting. Is it someone thriving or maybe someone really struggling? It feels so personal, but figuring it all out, that can be tough.
It really can. The information is just everywhere, sometimes conflicting.
Absolutely.
Yeah.
Our understanding is often, a bit of a patchwork. Personal stuff, things we see in the media, maybe bits we pick up here and there. It gets complex fast.
And that's exactly why we're doing this deep dive today. Welcome to the deep dive. We take source material listeners share and we unpack it, find the key ideas, the surprising bits, the practical stuff.
Right. And for this one, the source we're working with is really comprehensive. Think of it almost like a blueprint, covering the absolute foundational concepts in mental health and psychiatric nursing. It's dense, but really valuable stuff.
So our mission today is to walk through this blueprint with you. We want to pull out those core ideas, the definitions, how it applies in real life so you can get a solid handle on these building blocks without feeling totally overwhelmed.
Exactly. This is for you listening right now. Maybe you're learning for yourself, maybe for work, or maybe you're just curious about how the mind works.
Okay, let's unpack this blueprint together and see what jumps out.
Makes sense. We should probably start right at the beginning, shouldn't we? Defining what we actually mean by mental health and mental illness. The source gives us a pretty clear starting point.
Yeah, it does. Mental health, it's not just, not being sick. It's described as a state of well-being, being able to use your abilities, cope with normal life stress, work productively.
And contribute to your community. It's really a positive state of functioning.
Definitely. And then mental illness is defined as, well, a diagnosable disorder. The key thing is these significant disturbances, not just having a bad day, but real issues in thinking or emotion regulation or behavior.
And crucially, these disturbances cause real distress, or they make it hard for someone to actually function in their daily life. That impairment piece is key.
So it's not just about feeling bad, it's about the impact it has, right? Does it stop you from living your life the way you want or need to?
Exactly. And probably the biggest takeaway right off the bat from the source is that these aren't two separate boxes. You're not just in one or out of the other.
Ah, right. It's more like a continuum, a sliding scale.
Precisely. A fluid continuum.
Yeah.
The source lays it out nicely. On one end, you've got mentally healthy, you're coping well, adapting, functioning, thriving, really.
Okay. And then?
Then there's this middle area, emotional problems or mental distresses.
Yeah.
This is where maybe you're dealing with temporary stress, finding it hard to cope for a bit, maybe some mild symptoms pop up. A lot of us move in and out of this space.
Yeah. That sounds familiar. Things happen, you struggle for a bit, maybe get some support and work through it.
Exactly. And then at the other end is mental illness, where you have those diagnosable conditions that cause more significant, persistent challenges and impact daily life more seriously.
But the key is that movement along the scale isn't just one way, right? It's dynamic. Things can shift you back and forth.
Totally dynamic, influenced by so much. And that leads perfectly into resilience. This is a huge concept.
Resilience. How does the source define that?
It's defined as the ability to bounce back, to recover from or adapt well when you're facing adversity, trauma, tough times, significant stress.
It sounds like a mental superpower.
Yeah.
And it plays a role in prevention, right? Helping you handle stress without getting derailed.
Absolutely. It helps buffer against the negative impacts. And if someone does develop a mental illness, resilience is critical for their recovery,
Yeah.
helping them cope, sustain progress, manage challenges along the way.
Can you build resilience? Or is it just something you have or don't have?
Oh, you can definitely build it. That's the good news. Things like strong social connections, learning effective coping strategies, feeling empowered, these all foster resilience. It's not fixed.
That's really hopeful. So thinking about what pushes you along that continuum we talked about, the source contrasts risk factors and protective factors.
Right. Risk factors make you more vulnerable, increase the chances of moving towards the illness end. Protective factors act like a shield, promoting well-being.
Okay, so what are some examples of risk factors?
Things like genetic predisposition, family history, experiencing trauma, especially early life trauma. Substance use is a big one. Socioeconomic factors like poverty, instability, and dealing with chronic physical health problems.
Makes sense. And the protective factors, things that help.
Strong social support, friends, family, community. Stable employment, education, having healthy ways to cope with stress, and importantly, access to good health care when you need it. It really drives home how interconnected everything is: mind, body, environment.
This naturally brings up that whole nature versus nurture debate, doesn't it? Where do these challenges come from?
And the source is clear. It's both. Definitely both. Nature gives us the biological foundation, our genes, brain structure, those neurochemicals we'll get into later.
And nurture is everything else. Our experiences, how we were raised, the environment, social factors.
Exactly. But the really key insight here, the model that integrates both, is the diathesis stress model. This is crucial to understand.
Okay, break that down for us. Diathesis stress.
So diathesis is the predisposition or vulnerability. It might be genetic, biological, maybe even psychological from early experiences. It's like having a potential weak spot.
Okay, I've got the diathesis part.
But that vulnerability, that diathesis, might just sit there and not cause any problems until it encounters significant environmental stress. This could be a major life event, ongoing hardship, trauma.
Ah, so it's the combination. The underlying vulnerability meets a significant stressor, and that's what can trigger the disorder.
Precisely, it's the interaction. Like having dry, kindling diathesis that only catches fire when a spark stressor hits it. It explains why not everyone with a genetic risk develops an illness and why stress impacts people differently.
That makes a lot more sense than just blaming one or the other. The source also briefly mentions some history. Deinstitutionalization.
Yeah, back in the 1960s and 70s, that was the big movement away from keeping people long-term in large psychiatric hospitals towards providing care in community settings.
Driven by new medications and ideas about patient rights, right.
Okay.
Though it had mixed results in practice.
Very mixed. Good intentions, but community resources didn't always keep up, leading to other challenges. And to manage care effectively, you need some standardization, which brings us to the DSM-5.
The DSM-5. The Diagnostic and Statistical Manual of Mental Disorders. That's the big book clinicians use.
That's the one. It provides standard criteria for diagnosing different mental health conditions. It helps guide assessment, treatment planning, helps organize the different disorders.
And it's needed for practical things, too, like insurance justification.
Exactly. It provides a common language for clinicians, researchers, and even insurance companies.
Okay. And navigating all this complexity requires skilled guides. The source really highlights the role of psychiatric nurses here.
Yes, psychiatric mental health nurses, both RNs and advanced practice APRNs. They are described as true expert guides in this field.
What are their main roles, according to the source?
It's incredibly broad. Comprehensive assessment of patient needs, planning and carrying out care interventions, managing complex medications, stepping in effectively during crises.
That's a lot already.
And there's more. Educating patients and their families, advocating fiercely for patient rights, and collaborating really closely with the whole treatment team, doctors, therapists, social workers, everyone.
But what seems really central, based on the source, is their focus on the relationship.
Absolutely. Building that therapeutic relationship is foundational. Providing compassionate care that's also evidence-based, looking at the whole person, their emotional, thinking, and social needs, not just the diagnosis.
Okay, so we have a grasp on what mental health and illness are, the spectrum, and the key players. Now, how do we understand why things go wrong and how to help? Theories.
Right, exactly. These different theoretical lenses are like different maps for understanding the mind and behavior. Each gives a unique perspective.
Let's start with behavioral theory. Pavlov, Skinner. Rings a bell. Pun intended.
Yes. The core idea is simple. Behavior is learned through association, like Pavlov's dogs, or through consequences, rewards, and punishments, like Skinner's work with operant conditioning.
And if behavior is learned,
It can be unlearned or modified. That's the key insight. Techniques like positive reinforcement, rewarding good behavior, or systematic desensitization for phobias, where you gradually face the fear, stem from this. Token economies in treatment settings, too.
how do nurses use this?
Practically, it might involve reinforcing positive coping behaviors, setting clear expectations for behavior on a unit, maybe using behavioral contracts to help someone structure their goals.
Okay, next map. Cognitive theory. Aaron Beck comes to mind.
Right. This one focuses squarely on our thoughts. The central idea is that how we think directly influences how we feel and what we do. Specifically, distorted or negative thought patterns can lead to distress and problem behaviors.
And this leads to CBT, cognitive behavioral therapy.
Exactly. And the source points out that CBT is probably the most commonly used evidence-based therapy today. The whole goal is to help people identify those unhelpful, automatic, negative thoughts.
Like, I'm worthless, or this will definitely end badly.
Yeah, those kinds of thoughts. Identify them, challenge their validity, and learn to reframe them into more realistic, balanced, or helpful perspectives.
So a nurse might help someone keep a thought log, or practice challenging those negative automatic thoughts.
Precisely. Help them recognize the patterns, question them, practice positive self-talk. It's very skill-based.
Then there's the humanistic approach. Maslow, Carl Rogers. Feels a bit warmer, maybe.
It definitely emphasizes different aspects, focuses on our innate drive towards growth, self-actualization, becoming our best selves. Key concepts are empathy, genuineness from the therapist or nurse, and unconditional positive regard.
Unconditional positive regard. Accepting the person no matter what.
Exactly. Valuing the person inherently, without judgment. This leads to person-centered therapy, where the goal is to create a safe, supportive environment for the client to explore themselves and find their own answers and path to growth.
So for nurses, this translates into creating that non-judgmental atmosphere, encouraging self-expression, respecting their autonomy.
Absolutely. It's
Oh.
about the quality of the relationship and the environment fostering that inner growth potential.
This theory brings up self-actualization. What does that look like, practically?
The source describes it as realizing your full potential, becoming the most authentic you. In simpler terms, it means really understanding and accepting yourself, living with purpose, pursuing growth, seeking meaning.
It's the top of Maslow's hierarchy of needs, isn't it? That ultimate goal.
It is that drive to be all that you can be.
So, taking these theories together, it sounds like a good therapist or nurse needs to be flexible, draw from different approaches.
Definitely. Understanding behavior is useful, understanding thoughts is crucial, and fostering that human potential is also vital. It's about integrating these perspectives to best help the individual.
Okay, switching gears a bit. The source covers a specific medical intervention, ECT, electroconvulsive therapy.
Right. This is a medical treatment, not a first-line therapy usually. It's indicated for severe conditions like treatment-resistant major depression, some forms of bipolar disorder, especially mania, or acute psychosis when other treatments haven't worked or aren't working fast enough.
How does it work?
It involves inducing a brief, controlled seizure by passing a carefully measured electrical current through the brain. The patient is under general anesthesia and given muscle relaxants so they don't convulse physically.
And the nurse's role is critical throughout this. What does the source say about that?
Absolutely critical. Before the procedure, ensuring informed consent is solid, checking MPO status, giving pre-meds, removing potential hazards like dentures or jewelry, basically prepping the patient safely.
During the procedure.
They're assisting the team, monitoring vital signs continuously, making sure the airway is clear, observing and timing the seizure activity itself, providing support.
And afterwards, recovery sounds important.
Very. Post-anesthesia care, monitoring airway, breathing, circulation, neurological status. Reorienting the patient is key because confusion and some short-term memory loss right after the procedure are common expected side effects. And meticulous documentation and education for the patient and family are essential.
Okay. Let's move from interventions back to the brain itself.
Yeah.
Neurotransmitters.
Yeah.
The chemical messengers.
Yeah, this is fascinating stuff. The source emphasizes that imbalances in these chemicals are strongly linked to many psychiatric disorders. It's like the brain's communication network isn't quite tuned right.
Let's run through the key ones mentioned. Dopamine.
Dopamine. Think pleasure, reward, motivation, also movement. The feel-good and get-up-and-go chemical. Too much. Linked to symptoms like psychosis and schizophrenia, mania, addiction. Too little. Can contribute to depression, that lack of pleasure or motivation called anhedonia, attention problems, and Parkinson's disease on the movement side.
Okay. Serotonin. Often hear about that one with depression.
Right. Serotonin influences mood, sleep, appetite, digestion, often linked to feelings of well-being, calm. Low levels are commonly implicated in depression and anxiety disorders, insomnia, but too much is also dangerous, can lead to serotonin syndrome.
No kind of frame.
Part of the body's stress response system. Think alertness, energy, focus, also mood, like the brain's accelerator or alarm. Too much can contribute to anxiety, feeling wired. Too little is linked to depression, fatigue, lack of focus.
GABA. Sounds important for anxiety.
Very. Gamma-aminobutyric acid is the brain's main inhibitory neurotransmitter. It's the brake pedal. It calms things down, reduces neuronal excitability. Low levels are associated with anxiety, seizures, maybe even some symptoms of schizophrenia. Many anti-anxiety meds work by enhancing GABA.
And its counterpart, glutamate.
Glutamate is the main excitatory neurotransmitter, the gas pedal. Crucial for learning, memory formation. But too much can be overstimulating, even toxic to neurons implicated in seizures, maybe some neurodegenerative diseases like Alzheimer's or ALS. Too little might impair cognition.
Lastly, acetylcholine.
Also important for learning and memory, as well as muscle function outside the brain. Low levels in the brain are significantly linked to Alzheimer's disease, contributing to memory loss. High levels can cause specific physical symptoms like increased salivation or blurry vision.
Understanding these really helps make sense of how psychiatric medications work, doesn't it?
Absolutely. The source classifies the main types based on what they do. Antidepressants are a huge category.
Like SSRIs.
Yes. SSRIs, selective serotonin reuptake inhibitors, are the most common first-line treatment. They work by blocking the reabsorption or reuptake of serotonin, leaving more available in the synapse. SNRIs do the same for both serotonin and norepinephrine.
What about older ones?
Older classes include TCAs, tricyclic antidepressants, and MAOIs, monoamine oxidase inhibitors. They also boost norepinephrine and serotonin, but TCAs tend to have more side effects, and MAOIs require strict dietary restrictions to avoid dangerous interactions.
Okay. Anxiolytics. For anxiety.
Right. Benzodiazepines like lorazepam, diazepam, alprazolam are very effective for short-term anxiety relief. They enhance GABA's calming effect, but they come with significant risks like sedation, dependence, and withdrawal.
Are there non-benzo options?
Yes, like buspirone. It affects serotonin receptors, is non-sedating, not addictive, and better for long-term anxiety management, though it takes weeks to work.
Mood stabilizers. For bipolar disorder.
Exactly. Lithium is the classic example. Very effective, but it's a high-alert drug because the therapeutic dose is close to the toxic dose, requiring careful blood level monitoring. Anticonvulsants, originally developed for seizures, like valproic acid or lamotrigine, are also widely used to stabilize mood, often by affecting GABA or glutamate pathways.
Antipsychotics. For psychosis, schizophrenia.
Yes, they primarily work by blocking dopamine receptors. The older typical antipsychotics are effective but have a higher risk of movement side effects, called extrapyramidal symptoms or EPS. The newer atypical antipsychotics block dopamine differently and also affect serotonin, generally having a lower risk of EPS, but potentially more metabolic side effects like weight gain.
And stimulants.
Used mainly for ADHD. They increase dopamine and norepinephrine levels to help improve focus, attention, and impulse control.
So the medications are essentially trying to retune those neurotransmitter systems.
That's the goal.
Yeah.
But it's complex, and these are powerful substances with potential downsides. The source stresses safety.
What are the big safety flags?
Several crucial ones. Increased suicide risk, especially in younger people, when starting antidepressants requires close monitoring. Serotonin syndrome from too much serotonin activity, often from combining meds.
The MAOI food interaction.
Yes. The hypertensive crisis risk with MAOIs if you eat foods high in taurine-aged cheeses, cured meats, etc. Very dangerous.
Movement disorders with antipsychotics.
Right, EPS like stiffness or tremors, and the potentially irreversible tardive dyskinesia, involuntary movements. Also, the rare but life-threatening neuroleptic malignant syndrome, NMS, high fever, rigidity, confusion.
And lithium toxicity.
Definitely. Need to watch for early signs like tremors, GI upset, confusion. Regular blood level checks are vital.
Benzodiazepine risks.
Dependence and difficult withdrawal are major concerns. Plus sedation, falls risk. Requires careful prescribing and tapering. And liver-kidney function needs monitoring with many of these meds. It's a serious undertaking.
Absolutely. Okay, let's shift from biology and meds to the environment of care. The source talks about the least restrictive setting, LRE.
Yes, and this isn't just a suggestion. It's a core legal and ethical principle in mental health care.
What does it mean exactly?
It means providing care in the setting that allows the patient the maximum possible independence, freedom, and autonomy while still ensuring their safety and that the treatment they need can be delivered effectively.
So it's a balance. How does that look in practice?
Think of it as a spectrum of care levels. The source gives examples. Least restrictive would be outpatient therapy, maybe weekly sessions while living at home.
Okay, more restrictive options.
You might move to an intensive outpatient program, IOP, or a partial hospitalization program, PHP. More structured therapy, several hours a day, several days a week, but still living at home. Then comes full inpatient hospitalization for 247 care and supervision during an acute crisis.
And the most restrictive.
That would be involuntary hospitalization, being admitted and held for treatment against your will, based on legal criteria like being a danger to self or others. The goal is always to use the least restrictive level that meets the patient's needs safely and to step them down as soon as possible.
And within whatever setting they're in, the source emphasizes the milieu. What is that?
The therapeutic milieu is the environment. It's the physical space, the emotional atmosphere, the social structure, the daily routine. The key insight here is that the milieu isn't just the backdrop for treatment, it is part of the treatment itself. It's designed to be therapeutic.
What makes a milieu therapeutic?
Key components mentioned are safety, both physical safety, preventing harm, removing dangerous items, and emotional safety, feeling secure, respected. Structure predictable routines, clear expectations, which helps reduce anxiety. Support consistent presence of trained staff providing help and guidance. Also, involvement encouraging patients to be active participants in their own treatment and the unit community. And validation acknowledging patients' feelings and experiences, treating them with dignity.
What are some practical safety priorities in managing the milieu?
Things like carefully checking for and removing contraband items patients could use to harm themselves or others, like belts, shoelaces, glass, cords. Doing regular safety checks on the environment and the patients themselves. Also, constantly monitoring for any signs of escalating agitation or suicidal ideation, ensuring staff consistency so patients know who to turn to, and actively promoting healthy communication and conflict resolution skills among everyone on the unit.
The source also explains a specific legal tool used in Georgia, the 1013 form.
Right. This is specific to Georgia law, but similar emergency hold processes exist elsewhere. A 1013 is a legal document used for involuntary transport and admission for a psychiatric evaluation and stabilization.
Who can initiate it and under what circumstances?
Certain licensed professionals, physicians, psychologists, clinical social workers, etc., can issue it if they believe someone has a mental illness. A&D poses an imminent risk of harm. That means immediate danger.
Danger to who?
To themselves, suicidal, to others, homicidal, violent, or is so gravely disabled by their illness they cannot provide basic care for themselves and are at risk. Imminent risk is the key trigger.
And what does the 1013 actually do? Is it long-term commitment?
No, absolutely not. That's a critical distinction. The 1013 is an emergency hold. Its purpose is to allow for safe transport to a designated psychiatric facility and hold the person there for evaluation and stabilization for up to 72 hours.
Only 72 hours? What happens then?
At the end of the 72 hours or sooner, one of three things must happen. The person is stable enough to be discharged, they agree to stay voluntarily for further treatment, or if they still meet involuntary criteria and refuse voluntary treatment, the facility must initiate formal court proceedings to petition for longer-term commitment.
So the 1013 is just the emergency front door, not the whole house.
Exactly. It's a temporary measure for urgent safety and evaluation.
Got it. So quick recap. LRE maximizes independence safely, and the milieu uses the environment itself to promote healing.
That's the essence of it.
Now, a really important point the source makes. Even when someone is in a hospital, even involuntarily, they still have rights.
Absolutely fundamental. Being hospitalized doesn't strip you of your basic civil rights. The source lists several key ones.
Right.
The right to informed consent, understanding treatments, and agreeing to them. The right to refuse treatment to this is complex and can be legally overridden in specific situations like emergencies or under a commitment order, but the right exists.
Privacy, too.
Yes, the right to privacy and confidentiality protected by laws like IPA. The right to communicate with people outside, sending, receiving mail, having visitors, making phone calls. Those facilities can set reasonable safety rules around these.
And the right to a safe environment and that LRE principle again.
Exactly. The right to be treated humanely in a safe setting and the right to receive that treatment in the least restrictive way possible. These rights are protected.
Okay. Shifting slightly, the source addresses the difficult issue of potential violence in psychiatric settings. What are some risk factors?
Some common ones identified include a history of violent behavior. Past behavior is often a predictor. Active psychotic symptoms, especially paranoia or command hallucinations telling them to harm someone. Substance intoxication or withdrawal can lower impulse control, and conditions involving poor impulse control, like severe mania.
How do nurses intervene when someone is escalating?
The first approach is always de-escalation, using verbal and nonverbal techniques. A calm tone of voice, giving the person space, maintaining a non-threatening posture. Also, trying to remove triggers or potential weapons from the immediate area. Having clear emergency protocols and knowing staff backup is available is crucial. And maintaining that structured, safe milieu helps prevent many situations from escalating in the first place.
Are there protections for staff?
Yes, healthcare workers have legal protections, and facilities are required to have workplace violence prevention programs and training. It's a serious concern. Sometimes, despite all efforts, de-escalation fails and the situation becomes dangerous. The source discusses seclusion and restraints.
And it's very clear these are a last resort, right?
Absolutely. Unequivocally a last resort. Used only when the patient poses an imminent danger to themselves or others, And less restrictive interventions, like verbal de-escalation, offering medication, have failed or are not appropriate for the immediate danger.
What are the rules around using them? They sound strict.
Extremely strict, legally and ethically. You need a specific order from a qualified provider, and that order is time-limited, often just for a few hours, needing frequent reassessment and renewal, usually no longer than 24 hours per order. The patient must be monitored continuously, often 1.1 observation, sometimes via video audio if protocols allow. Regular checks for physical needs, safety, and readiness to come out are required. And they must be discontinued the moment it's safe.
What's the difference between seclusion and restraint?
Seclusion is involuntarily confining a person alone in a room they cannot leave. Restraints involve using physical methods like holding or mechanical devices like soft limb holders to restrict freedom of movement.
The key takeaway feels like shortest time possible, only for safety, never for punishment or staff convenience.
Exactly that. And documenting every single aspect of these situations is non-negotiable.
Documentation seems critical throughout psychiatric care.
It's paramount. The source lists why. It's legal protection for everyone involved. It ensures continuity of care. The next shift knows what happened. It helps evaluate if interventions are working. And it provides accountability.
What kinds of things need to be documented?
Objective observations. What did you actually see and hear? Avoid interpretations. Patient statements should be in quotes whenever possible. What interventions did you use? De-escalation, meds offered, restraints applied. How did the patient respond? Crucially, document the specific behaviors that necessitated restraint or seclusion. Exact times when started, when ended, when reassessments occurred. Any education provided to the patient. Who was notified, doctor, family if appropriate. It needs to be a clear, factual, chronological record.
This careful process ties into the overall framework nurses use the nursing process.
Right. It's that systematic, problem-solving approach applied specifically to psychiatric care. Assessment, diagnosis, planning, implementation, evaluation, ADPIE.
Let's walk through that quickly in a psych context. Assessment.
Gathering all the data. Doing the mental status exam, MSE, the psychosocial assessment we'll touch on. Interviewing the patient, maybe family. Reviewing history, labs, asking about mood, sleep, hallucinations, always asking about suicidal or homicidal thoughts, SIHI, psych history, substance use, culture, spirituality, getting the whole picture.
Diagnosis, but not the medical one.
Correct. Identifying nursing diagnoses based on the assessment data. These focus on the patient's response to their illness or life situation. Examples the source might give. Risk for suicide, disturbed thought processes, ineffective coping, social isolation.
Planning. Setting goals.
Yes. Collaborating with the patient to set SMART goals, specific, measurable, achievable, relevant, time-bound. Prioritizing safety needs first. An example goal. Client will identify 2 personal coping strategies by end of shift.
Implementation. Doing the plan.
Putting the nursing interventions into action. This could be administering medications safely, doing those 15-minute safety checks, providing teaching about meds or coping skills, using therapeutic communication, facilitating group therapy attendance.
And evaluation. Checking if it worked.
Exactly. Assessing whether the planned outcomes were met. Did the patient meet their goal? Is their anxiety reduced? Are they safe? If goals weren't met, you reassess and revise the plan. It's a continuous cycle.
And documentation weaves through all of it.
It's like the unofficial 6th step, documenting every other step along the way.
You mentioned 2 key assessment tools, the MSE and the psychosocial assessment. What's the MSE?
The mental status exam is like the psychiatrist or nurse's head-to-toe assessment, but focused on mental functioning right now. It's a snapshot.
What does it cover?
Key categories you observe are asked about: appearance, hygiene, dress, behavior, activity level, eye contact, mannerisms, speech, rate, volume, clarity, mood, what the patient says they feel, e.g. depressed, anxious, and affect, the emotional expression you observe, flat, tearful, bright. Also, thought process, how they're thinking, logical, tangential, disorganized. Thought content, what they're thinking about, preoccupations, delusions, always assess SIHI, perception, any hallucinations, hearing voices, seeing things, cognition, orientation to person, place, time, memory, attention, and finally, insight and judgment. Do they understand their situation? Can they make reasonable decisions?
Okay, that's a thorough snapshot. How is the psychosocial assessment different?
If the MSE is the snapshot, the psychosocial assessment provides the context, the whole person picture, and their environment. It's usually done alongside or as part of the initial intake.
What goes into that?
Key areas include the chief complaint, why they sought help, in their own words, history of present illness, details of current symptoms, past psychiatric history, diagnoses, treatments, hospitalizations, medical history, family psychiatric history, important for genetic links. Also, substance use history, type, amount, frequency, social history, living situation, work, school, relationships, support system, trauma history, and cultural and spiritual beliefs, how these impact their understanding of health and illness, coping. You use open-ended questions, build rapport.
Does the assessment approach change based on age?
Yes. The source notes important adaptations. With children, you might use play therapy, drawing, get more info from parents, use simpler language. With adolescents, establishing trust and ensuring confidentiality within limits is key. You screen carefully for risk-taking behaviors. With older adults, you need to screen for sensory deficits or cognitive changes that might affect the interview, speak clearly, maybe involve caregivers if needed. You tailor the approach.
This leads us perfectly into what feels like the cornerstone, building that therapeutic relationship.
Absolutely. The source defines its core purpose: to promote the patient's healing, recovery, and growth. It's built on a foundation of trust, empathy, and clear professional boundaries.
How is it different from just being friendly or having a personal relationship?
That's a critical distinction. The source highlights key differences. Focus. In a therapeutic relationship, the focus is solely on the client's needs and goals. In a personal one, it's mutual. Time frame. Therapeutic is time-limited, tied to treatment goals. Personal is usually ongoing. Communication. Therapeutic communication is structured, purposeful, focused on the client's issues. Personal is informal, spontaneous, often emotionally driven. Boundaries. Therapeutic boundaries are clear, professional, protecting both parties. Personal boundaries are flexible, blurred.
The insight being it's not friendship, it's a professional alliance for the patient's benefit.
Precisely. And building it requires specific qualities from the nurse. Trustworthiness, being reliable, consistent. Empathy, the ability to understand and share the feelings of another. Feeling with, not just sympathy or feeling for. Genuineness, being authentic, congruent. Positive regard, accepting the patient as a worthwhile person unconditionally. Active listening, and maintaining those professional boundaries.
Let's talk more about boundaries. They're legal and ethical too, right?
Yes. Legal, ethical, professional limits that define a safe connection. Examples include physical boundaries, respecting personal space, appropriate touch only with consent. Emotional boundaries, staying objective, not oversharing personal problems, avoiding over-identification. And social role boundaries, maintaining the nurse-patient role, not becoming friends, avoiding dual relationships outside of therapy, limiting self-disclosure.
What are the warning signs if boundaries get blurred?
The source mentions 2 levels. A boundary crossing is a brief, perhaps minor deviation that might be acceptable in a specific therapeutic context, but needs careful thought and documentation. For example, accepting a small, inexpensive thank you gift. A boundary violation, however, is harmful or exploitative. It exploits the patient's vulnerability. Examples include romantic or sexual comments behavior, asking for or accepting significant favors or money, excessive self-disclosure by the nurse that shifts the focus, keeping secrets with the patient. These are serious breaches.
There are also these concepts, transference and countertransference.
Yes, unconscious dynamics that often pop up. Transference is when the patient unconsciously redirects feelings and attitudes they have about significant people from their past, like a parent, onto the nurse. They might react to the nurse as if they are that other person.
Example.
A patient whose father was very critical might perceive constructive feedback from the nurse as harsh criticism and react defensively, saying, "You're just like my dad."
And countertransference.
That's the reverse. The nurse unconsciously redirects their own feelings or attitudes about someone from their past onto the patient. Maybe a patient reminds the nurse of their younger sibling, and the nurse becomes overly protective or lenient. Or a patient triggers unresolved anger related to a past relationship.
So awareness is key for the nurse, to not let their stuff interfere.
Self-awareness is crucial for recognizing and managing countertransference to maintain objectivity and therapeutic focus.
This relationship develops over time, doesn't it? Paul's phases.
Right. Hildegard Paplaw described phases. Pre-orientation. Before you even meet the patient, the nurse examines their own feelings, biases, gathers initial info. Orientation. The introduction phase. Building rapport and trust, defining roles, discussing confidentiality, setting initial goals together. Testing behaviors are common here.
Working phase.
This is where the bulk of the therapeutic work gets done. Implementing interventions, active problem solving, patient explores issues more deeply, nurse facilitates change. Cohesion builds, but transference, countertransference might emerge strongly here too.
Termination phase.
The ending. It's planned. Reviewing progress made, discussing feelings about ending the relationship, which can involve sadness, loss, or pride. Planning for continued support. The nurse helps provide closure.
And driving this whole relationship is communication, therapeutic communication.
These aren't just random conversation skills. They are specific techniques used intentionally to help the patient.
What's the goal?
To build trust, encourage the patient to express thoughts and feelings openly and safely, gain understanding, and ultimately promote healing and change.
What are some key techniques the source mentions?
Active listening, really concentrating, understanding, responding, remembering what's said. Using open-ended questions, ones that require more than a yes or no answer. Tell me more about. Restating, repeating the main idea the patient expressed, so you're saying. Reflecting, directing the patient's feelings or questions back to them for exploration. What do you think you should do? Using silence, strategically giving the patient space to think and speak. Clarifying, checking understanding. I'm not sure I follow. Could you explain? Summarize and pulling together key themes or progress.
Just as important as knowing what not to do, right? Non-therapeutic responses.
Definitely. These tend to shut down communication or make the patient feel invalidated. The source lists common ones. Giving premature advice takes away their autonomy, implies you know best. Minimizing feelings, don't worry, it's not that bad, dismisses their experience. Asking why. Questions can sound accusatory or judgmental, put them on the defensive. Abruptly, changing the subject avoids difficult topics the patient brought up. Giving false reassurance everything will be fine offers empty platitudes and blocks exploration of real fears.
Communication isn't just words either. Verbal versus nonverbal.
Right. Verbal is the spoken or written word. Nonverbal is everything else. Body language, posture, gestures, facial expressions, tone of voice, eye contact, use of space.
Which is more powerful?
Nonverbal often conveys more and is frequently unconscious. The key insight is the need for congruence. The verbal message and the nonverbal message should match. If someone says, "I'm fine," while looking down and fidgeting, you trust the nonverbal more. Lack of congruence signals distress or conflict.
This all comes together in the clinical interview, that initial meeting.
Exactly. The goal is threefold. Establish trust and rapport, gather crucial assessment data like the MSE and psychosocial info, and begin that therapeutic alliance.
What makes for a good interview setting and approach?
Setting: quiet, private, ensuring physical safety for both. Seating: ideally at eye level, maybe angled slightly, not behind a big desk barrier. Pace: let the patient set the pace, don't rush. Introductions: clearly state your name, role, purpose of the interview, approach. Start with open-ended questions to encourage them to talk. Use attending behaviors, active listening, nodding, appropriate eye contact. Use clarifying questions. Crucially, use non-judgmental language and tone.
The outcome is more than just information. It's the start of the relationship.
Precisely. It sets the stage for everything that follows.
Okay, let's shift focus to something universal. Stress. The source breaks down its effects really well.
It does. First, the immediate short-term physiological response. That's the fight or flight kicking in sympathetic nervous system activation.
Heart pounds, breathing quickens, muscles tense.
Right. Increase heart rate, blood pressure, respiration, muscles get tense, you become hyper-alert, your body releases adrenaline and cortisol, dumps glucose into the bloodstream for energy.
And the purpose of all that?
Immediate survival. It prepares you to either confront the danger or run away from it. Very adaptive for short-term threats. The problem arises when stress becomes chronic.
What happens then? The long-term effects?
When the stress response stays activated long-term, it starts causing wear and tear, dysfunction. The source highlights major impacts. Immune system suppression, making you more vulnerable to illness, increased risk of cardiovascular problems, high blood pressure, heart disease, GI issues, ulcers, IBS, reproductive problems, sleep disturbances. And it can significantly worsen existing chronic conditions like diabetes or autoimmune disorders. It ties into Selle's general adaptation syndrome. If stress continues, you hit the exhaustion phase where systems break down.
How we respond isn't just automatic, though. Other factors influence it.
Absolutely. Stress response is mediated by several factors. Your perception of the stressor is huge. Do you see it as a threat or a challenge? Your underlying temperament or personality plays a role. And crucially, mediating factors like social support, having people to lean on, cultural beliefs about stress and coping, spirituality or religious beliefs can be a buffer. Access to support groups. Stress is incredibly subjective.
Can we measure stress?
There are tools. The source mentions the recent Life Changes questionnaire, which assigns points, life change units, to different major life events like divorce, job loss, moving. Higher scores correlate with increased risk of illness in the near future, highlighting that mind-body link.
So what can nurses do to help people manage stress?
A lot. The source lists practical interventions nurses teach and support. Relaxation techniques are big. Deep breathing exercises, progressive muscle relaxation, tensing and releasing muscle groups, guided imagery using visualization, meditation, mindfulness practices, focusing on the present. Biofeedback can help people learn to control physiological responses. Cognitive techniques are also key. Cognitive reframing, challenging negative interpretations, journaling, practicing positive self-talk, effective problem solving, and goal setting.
What's the nurse's overall role?
Assess the patient's stress levels, their current coping mechanisms, their support systems. Intervene by teaching these stress management techniques, encouraging use of supports, referring for therapy if needed. Educate about the effects of chronic stress and lifestyle factors. And monitor symptoms, see if coping is improving.
When stress isn't managed well, it often leads to anxiety. The source uses Peplaw's levels of anxiety.
Yes, a really useful way to understand anxiety's intensity. 4 levels. Mild anxiety, normal. Actually helpful. Heightens perception, sharpens focus, allows for effective problem solving. You might feel slight restlessness.
Moderate anxiety.
Perceptual field narrows. You start to tune out some things, selective inattention. Problem-solving ability is hampered, but still possible. Physical symptoms become more noticeable, increased heart rate, muscle tension, maybe GI upset.
Severe anxiety.
Perceptual field is greatly reduced. Focus is scattered or fixed on small details. Problem solving is ineffective. Physical symptoms are much more intense. Pounding heart, sweating, hyperventilation, maybe headache, dizziness. Subjectively, feels like dread or impending doom.
And panic level anxiety.
The most extreme. Perceptual field might be closed, unable to process what's happening. Thinking is disorganized, learning is impossible. Intense terror, feeling of losing control, going crazy, or dying. Can involve dissociation, perceptual distortions like hallucinations. Behavior might be frozen or hyperactive, agitated, a state of profound disorganization.
When facing anxiety, people use defense mechanisms too, right? Unconsciously.
Exactly. These are unconscious strategies the ego uses to protect itself from anxiety, conflict, or unacceptable thoughts, feelings. They're not inherently bad. It depends on how much and how often they're used. The source gives examples of adaptive, helpful, versus maladaptive, unhelpful uses.
Like denial.
Adaptive. Briefly deny a shocking diagnosis to cope initially. Maladaptive. Persistently denying a serious substance abuse problem despite clear evidence.
Placement.
Adaptive. Punching a pillow when angry at your boss.
Yeah.
Maladaptive. Yelling at your spouse or kids because you're angry at your boss. Redirecting the feeling onto a safer target.
Rationalization.
Adaptive. Finding a silver lining after a disappointment. It wasn't the right job for me anyway. No. Maladaptive. Justifying cheating on taxes because everyone does it. Making excuses. Projection. Attributing your own unacceptable feelings to someone else. Maladaptive. Feeling attracted to someone else while married, then accusing your spouse of flirting. Sublimation is often seen as mature adaptive, channeling unacceptable impulses, like aggression, into socially acceptable activities, like competitive sports or intense workouts.
What makes someone more prone to developing anxiety or OCD disorders?
Similar risk factors we've seen. Genetics play a role. Brain structure function differences, like hyperactivity in the amygdala, the fear center, childhood trauma or adversity, certain personality traits like neuroticism, chronic physical illness, substance abuse or withdrawal, and of course, significant stressful life events.
Applying the nursing process here, assessment would involve
Determining the level of anxiety, using Peplaw's levels, identifying triggers, assessing for physical symptoms, checking for obsessions, intrusive thoughts, or compulsions, repetitive behaviors, in OCD.
Nursing diagnoses could be
Priority might be anxiety, ineffective coping, risk for injury, especially during panic, maybe chronic low self-esteem, or even impaired skin integrity if compulsive washing is involved.
outcomes would focus on
Patient verbalizing, reduced anxiety, demonstrating coping skills, participating in therapy, maintaining safety,
and interventions.
using calm, supportive communication, staying with the patient during severe anxiety panic, teaching relaxation and grounding techniques, helping identify triggers and develop coping plans, encouraging journaling or physical activity. For OCD, a key point: do not interrupt rituals abruptly as this spikes anxiety. Work with the patient gradually. Providing structure and routine helps too.
Medications are common for anxiety. The source compares benzodiazepines and buspirone.
Yes, benzodiazepines, like alprazolam, Xanax, lorazepam, work quickly by boosting GABA. Very effective for acute anxiety or panic, but the huge caveat: high risk of sedation, dependence, tolerance, falls, especially in elderly, and difficult withdrawal. Generally recommended for short-term use only. Xanax has particularly high abuse potential. Avoid alcohol and other CNS depressants. Need to taper off slowly. Buspirone, Bospar is different. Non-benzo, works on serotonin. It's not addictive, not sedating. Good option for long-term management of generalized anxiety disorder, GAD. Downside. Takes 2 to 4 weeks to reach full effect, so it's not for immediate relief, not PRN. Need to take it regularly. And avoid grapefruit juice, as it can increase levels.
The source also briefly lists several specific anxiety and OCD-related disorders.
Right, just to differentiate them. Things like separation anxiety disorder, fear related to separation from attachment figures, specific phobia, intense fear of a specific object situation, social anxiety disorder, fear of social scrutiny, panic disorder, recurrent unexpected panic attacks, agoraphobia, fear of situations where escape might be difficult, and GAD, that persistent excessive worry. Then the OCD and related disorders cluster. OCD itself, obsessions and compulsions, body dysmorphic disorder, preoccupation with perceived flaws, hoarding disorder, trichotillomania, hair pulling, excoriation, skin picking.
What's the key difference in how these manifest, according to the source?
A helpful distinction provided. OCD anxiety is typically relieved temporarily by performing the compulsion. Phobias lead to avoidance of the feared stimulus. GAD is characterized by that chronic, pervasive worry across multiple areas.
Very much. Beyond individual approaches, groups are really important in mental health treatment.
Very much so. Therapeutic groups offer support, shared experience, learning from peers. The source outlines the typical developmental phases groups go through.
Orientation.
The beginning. Group forms, members get acquainted, learn the purpose and rules. The leader sets the tone, manages anxiety. Members might be hesitant, testing the waters.
Working phase.
Trust deepens. Members engage more openly, work on problems, share feedback. Conflict might emerge, but gets resolved constructively with the leader's guidance. Group cohesion develops. This is where most therapeutic change happens.
Termination phase.
The end of the group. Members prepare to leave, reflect on their experience and progress. Feelings about ending sadness, loss, pride, accomplishment are processed. The leader helps facilitate closure and reinforces learning.
Groups aren't always smooth sailing. What about handling disruptive members?
The source gives strategies. For someone monopolizing, the leader needs to intervene respectfully but firmly, set limits on talking time, redirect, and actively encourage quieter members to participate. Create balance. For someone being disruptive, e.g. challenging rules, arguing, calm, direct redirection, remind them of group norms and purpose. Address the behavior, not the person. Maintain structure. For a silent member, gently invite participation. We haven't heard from you yet. Any thoughts? Use open-ended questions. Avoid putting them on the spot or pressuring them heavily. Acknowledge their presence, accept silence to a degree, but keep encouraging connection.
Lastly, the source touches on integrative care and complementary alternative medicine, CA.
Right. Integrative care is the big picture. Holistic, patient-centered care that combines conventional medical treatments with evidence-based complementary therapies. It treats the whole person, requires coordination and collaboration.
And the difference between complementary and alternative?
Complementary therapies are used alongside conventional medicine, obligatory, using acupuncture with pain medication. Alternative therapies are used instead of conventional medicine. For example, using a special diet instead of chemotherapy, often risky. CARAM use is increasing.
The source lists some common herbals and supplements used for mental health. What are the key takeaways and risks?
St. John's wort, used for mild, moderate depression. Huge risk. Interacts dangerously with SSRIs, can cause serotonin syndrome. Reduces effectiveness of birth control pills, blood thinners like warfarin, and many other drugs. Needs extreme caution. Kava, used for anxiety. Major risk. Potential for severe liver damage. Banned in some countries. Valerian root, used for insomnia, anxiety. Risk. Can cause significant sedation, drowsiness. Caution with driving or machinery. Omega-3 fatty acids. Fish oil, used for mood stabilization, depression. Risk. Can increase bleeding time. Caution of taking anticoagulants like warfarin. SAMe, used for depression, arthritis. Risk. Can potentially trigger mania in individuals with bipolar disorder. GI upset common. Melatonin, used for sleep. Generally safe short-term. Risk. Caution in people with seizure disorders, potential interactions. Drowsiness. Ginkgo biloba, used for cognitive function memory. Risk. Increases bleeding risk. Dangerous with blood thinners or before surgery.
The big message seems to be these aren't regulated like drugs, and interactions are a major concern.
Exactly. They are not FDA regulated for safety, purity, or effectiveness in the same way prescription meds are. Potency varies widely. Interactions and side effects are real.
So what's the nurse's role regarding Haman?
Absolutely critical. First, assessment. Nurses must ask every patient specifically about all CAM use, herbs, supplements, vitamins, everything, because patients often don't volunteer this info. Assess for potential interactions, perceived effectiveness, adherence, cultural meaning. Second, education. Provide evidence-based information or lack thereof. Direct patients to reliable resources like NCCIH, PubMed. Explain the lack of FDA regulation, potential risks, side effects, interactions. Stress the absolute importance of disclosing all CAM use to all healthcare providers.
Yeah.
And advocacy. Support informed decision-making. Encourage safe, coordinated use if the evidence supports it and is not harmful. Help incorporate safe, effective CAM into care plans when appropriate.
What about other types of chem?
The source mentions mind-body therapies like acupuncture, used for anxiety, depression, pain, substance withdrawal. Aromatherapy, using essential oils for stress, sleep, mood. Guided imagery for PTSD, anxiety, pain management. Also, meditation and mindfulness. Widespread use for stress reduction, mood regulation, focus. Energy therapies like therapeutic touch or Reiki, used for relaxation, reducing agitation, anxiety. And expressive therapies like art, music, or dance therapy. Powerful for nonverbal emotional expression and processing.
Wow, we have really covered a huge amount of ground from this blueprint.
We really have. From defining mental health and illness, exploring that whole spectrum, understanding the roots in nature and nurture, looking at different therapeutic theories and specific treatments like ECT and medications.
To the importance of the treatment setting, patient rights, communication, the nursing process, managing stress and anxiety, group work, and even CAM, it's a lot.
It really shows, doesn't it? This material, laid out like a blueprint, just reveals how many layers there are to understanding mental well-being and the incredibly intricate work involved in caring for people facing these challenges.
It's fascinating how it all weaves together the biology, the personal history, the environment, the relationships. It's not just one thing.
Not at all. And it truly underscores the vital role of skilled, informed, and empathetic guides like psychiatric nurses who use these frameworks, build relationships, communicate effectively, and manage complex situations to support people towards recovery.
So thinking about everything we've unpacked, the whole continuum, the interplay of factors, the vast array of tools from therapy and meds to mindfulness and support, what's one idea that really stands out to you, our listener, as potentially powerful for promoting well-being, whether it's for yourself or for your community? Something to chew on.
We really hope this deep dive has helped clarify some of these essential concepts and given you a solid foundation.